we're here again to further talk about the concept of multisensory integration. So what we want to talk about is when we're going to have a slightly harder time visualizing the structures that we're palpating. Remember that our patient positioning concepts, the fourth concept is I'd like the anatomy that I'm working on to be free to move, or to be exposed, free to move with the plane required, and preferably visible. The preferably visible points to the concept of multisensory integration. Now, if in a situation where I have a patient in supine, because there are times when patients can only be in one position, comfortably anyways, or it's only effective to have them in one position. That's something that you will learn through education and through clinical practice. So in a situation such as a patient in supine, if I want to palpate the vertebral column, my hand is now out of view. I cannot see my hand. So one of the things that I can do now is it's possible that people would suggest I should rely on haptic feedback or palpation alone. I will suggest again against that. So I prefer to have this visible, but I can still use my vision to make sure that what I believe I'm feeling, or to improve my capacity to believe that what I'm feeling is actually the movement of the structures that I'm attempting to move or attempting to palpate. One of the ways I can do that is again using the concept we discussed previously, that the structure under palpation may be obscured by the hand itself as it's being palpated. But what I can do is I can use my peripheral vision. In this case, it's not the structure being palpated isn't necessarily obscured by my hand. It's obscured because of where it is in relation to the table. So in this case, I'm touching the patient's vertebral column. What I'm going to do is use my vision in general to make sure that any motion that happens is motion of the vertebral column in the area being palpated as opposed to auxiliary motion. So this is another example where we can just very simply have the patient bend their knee. Okay? As they bend their knee, I would expect some motion of the vertebral column, but not all that much because the hip hasn't even got to 90 degrees or beyond, so I shouldn't expect any lumbar flexion. But what I can do is I can push across the table, and as I feel some motion in the lumbar column, now the lumbar column doesn't rotate much, but I should feel something. For me to understand whether or not the motion is in the lumbar column and not the thoracic column, at least the motion that I'm palpating, I'll use my eyes. If the patient's ribs start to move off the table or in relation to the table, then I know I've gone too far. So I'll move a little farther back. So there is motion in the lumbar column. As I get a little farther, I'm going to start to see. Now if it's visible, you look right around here, that's what I'm looking at. So I'm using broad vision. I look here, and then as that starts to move, and also in relation to my hand, as I feel less pressure on my hand from the patient's body, I now have two pieces of information that suggest the motion that I've created has gone farther than the region I'm palpating. So if I'm palpating the lumbar region and I feel less weight on my hand because it's under the patient, and I also see the patient's ribs move, I know I've gone too far. So I'm still attempting to use two senses to increase the possible accuracy of what I'm doing, but I'm also recognizing that I may have to rely more on haptic or palpatory feedback. I may have to, but I don't have to exclusively do it. So anytime the structure is on the other side of the patient, for whatever reason, magically you're in a place where your cable's against the wall and you can't get to the other side and you have to reach the other side, so you reach across the patient. Okay, you're going to use your vision to give you indications as to whether or not the movement's happening where you're palpating. You're still relying on a combination of senses to increase accuracy, to increase validity. So if the patient was in lateral and I was working in front of them, which we've talked about previously, then I'm at a loss for vision, so I'm going to have a harder time. That's one of the reasons why if I'm working on something on the posterior surface of the patient in lateral, I'd rather be on the other side. If the patient's in prone, then for whatever reason, I wanted to assess tension on the front. I'm very, very rarely, especially in prone, going to reach underneath the patient because it's quite uncomfortable. And if I ever did, I would make sure that I ask for permission and it's not in a sensitive area. However, in a situation like supine, if I'm underneath the patient palpating their posterior surface, such as the vertebral column or the angles of the ribs, then I'm still going to use vision. I'm not going to ignore it. So again, there's times when haptic feedback or palpatory feedback may be more appropriate or more dominant. However, I'm not going to ignore vision because the vision is going to give me another sense to combine with my palpation to let me know if what is happening is what I really think is happening, so that I know that if I think a large motion is happening in the lumbar column, but I see his ribs moving, or I see my patient's ribs moving, that I've gone too far. So at no point am I likely to remove vision from the equation. It's always going to serve me well, even if I can't see the structures. So as I said before, if in a situation where I can see the structure and I put my hand over it, it's obscured from view, but I'm still using my peripheral vision to guide me as to whether or not I'm accurately palpating what's going on. So I always combine my vision, or not always, but the majority of the time I'm going to use vision as that secondary cue, or even the dominant cue, to let me know about what's going on.